Greetings. Thank you for joining us this beautiful morning or afternoon, depending on where you are. My name is Dumiso Gacha. I am an advisory group member of the Civil Society Engagement Mechanism for UHC 2030. I welcome you to this virtual policy discussion on advancing access to immunizations for people on the move in the times of COVID-19, on the margins of World Immunizations Week. Just a few notes to mention. We will have automated closed captions. Everyone, please do remain on mute and turn off your video if you're not speaking. The audience members, please post your questions and comments on the chat box. We will be sharing some hashtag in the chat on social media participation. So please do make sure to use those hashtags, hashtag vaccines work, hashtag World Immunizations Week, hashtag vaccine equity. And if you will allow me to just mention a few notable items for this occasion. In 2020, global estimates for the number of persons forcibly displaced across national borders were 34 million. Around 281 million people live outside their country of origin, either due to labor, family migration, and humanitarian crises. The pandemic has aggravated vulnerabilities and inequality across the world. Routine health services, immunizations, and the delivery of life-saving treatment for other diseases have been disrupted. Lockdowns and other restrictions have led to shortages of food, water, and medicines, as well as put more people at risk of home-based violence, unemployment, and poverty. The COVID-19 pandemic has shown that most health systems around the world are not sufficiently resilient for people on the move who have historically been left behind by national health plans and programs. In the best of times, the added pressures of the pandemic threaten to render them invisible to response and recovery plans. This includes LGBTIQ refugees who have been under threat at the Kakuma refugee camp in Kenya, as well as foreign national sex workers in my country, Botswana, with no social protections or dignified treatment in terms of whenever they're engaging or facing law enforcement. Similarly, in women and children facing, if not escaping, the atrocities in Ethiopia's Tigray region. At the Civil Society Engagement Mechanism for UHC 2030, CSEM, the civil society constituency of the global movement for health system strengthening to achieve universal health coverage, we work to ensure UHC means all people have access to the healthcare they need and no one is left behind. Most essential to this is ensuring that civil society organizations and communities are meaningfully engaged. From early on in the pandemic, we have seen civil society filling in the gaps and working, often without institutional support, to ensure essential services and goods reach communities that have been left behind in response and recovery measures. Delivering food and medicines, providing psychosocial support, or continuing advocacy. Civil society remains a critical aspect of vaccine delivery. Civil society organizations and community-based organizations can link more people to vaccinations, including internally displaced persons, undocumented migrants, and those who are historically excluded. They are necessary to combat vaccine hesitancy and misinformation on the ground with not only scientific expertise, but also align and ensure an understanding of the community's needs. It is essential that the work of civil society and communities are tangibly supported and recognized as a core component for the vaccine rollout to ensure a pandemic response that leaves no one behind. CSEM also published a paper on the health and economic impacts of COVID-19 containment strategies on the most left behind. A clear recommendation is the need to center inclusion of the most marginalized and vulnerable to access, to address a pandemic that has been aggravated by pre-existing inequalities. People on the move often remain excluded from government agendas because of language, structural, legal, political, or financial barriers. Governments cannot afford to wait until they are out of their emergency response modes to engage with outlier communities. The delays in recognizing and listening to the voices of affected communities will counter any progress made to perpetuate inequities. With those few words, I would like to hand over to member states for our opening remarks. And we will start with Her Excellency, Ms. Rabab Fatima, Permanent Representative of Bangladesh to the UN.
I thank you, Mr. Moderator, and thank you for setting the tone for the meeting. Ambassador Flores, Deputy Director General Laura Thompson, SRSG Walter Cote, Excellencies, distinguished panelists, dear colleagues, a very good morning to all. I thank the organizers for inviting me today and for giving me this opportunity to share a few thoughts on a very important issue, that is advancing access to immunization for people on the move in times of COVID-19. We have with us a rich panel of experts to share their views on this important topic, and I hope that our discussion will lead to some bold and innovative ideas. Before I begin, I wish to pay my tribute to migrants globally who have been on the front line of the COVID battle and yet mostly kept outside of response and recovery efforts. I also thank and pay tribute to all frontline IOM, IFRC, ICRC, and CSEM staff who have been carrying out their work with courage and dedication during this unprecedented crisis. I thank you. Today's event coincides with the World Immunization Week 2021 with a very apt theme, vaccines bring us closer. Last Friday, we had a special ministerial meeting convened by ECOSOC on the theme vaccine for all. And last month, as many as 181 countries endorsed the political declaration on equitable global access to COVID-19 vaccines. We must build on such political momentum to ensure vaccines for everyone, everywhere. Migrants, refugees, as well as other people on the move, including those in irregular situations, should not fall through the cracks. The Secretary General's policy briefs on COVID-19 and the universal health coverage, as well as on people on the move, highlighted the importance of ensuring inclusive access to healthcare, regardless of migration status. It is encouraging to see the initiatives of some countries to facilitate access to vaccines, irrespective of their status. And in this regard, the United States and the United Kingdom have certainly led by example. In Bangladesh, we have included 1.1 million Myanmar nationals, the Rohingyas, in the national vaccination rollout campaign. We're using the same prioritization criteria for them as the Bangladeshi nationals. Excellencies, these are all steps in the right direction. Yet we are far away from ensuring fair and equitable distribution of vaccines for all. 86% of vaccination worldwide has been administered in high and upper middle income countries, and only 0.1% people in low income countries have received vaccines so far. We must overcome the stark vaccine divides. We believe that providing universal access of vaccines is intrinsically linked to the broader question of equity in production, distribution, and other socioeconomic issues. Vaccine hoarding, vaccine nationalism are not going to take us anywhere. No one is safe unless everybody is safe. And as the Secretary General has rightly said, at this critical moment, vaccines equity is the biggest moral test before the global community. Dear friends, let me share some specific thoughts in this regard. First, we commend the extraordinary level of cooperation and solidarity to create the COVAX facility to ensure vaccines to the world's most vulnerable. Since 84% of refugees are hosted by the low-income countries, COVAX comes as an important way out to bridge the burgeoning vaccine divide. We need more generous support from the developed countries, international organizations, philanthropists, MDBs, and vaccines producers to fulfill the ambitious targets of COVAX to reach those who are left furthest behind. Second, the COVID-19 pandemic has hit the countries that are hosting large number of refugees the hardest. The vaccines issue cannot be dealt in isolation of the multifaceted challenges that these countries are already facing, and that include the limited capacities of the public health facilities. The international community must enhance support to these countries to overcome these double crises of the pandemic and large-scale refugees. Thirdly, migrant and refugees face mirrored problems, including language and cultural barriers, lack of knowledge and access to healthcare system, difficulties in accessing internet, and various other socioeconomic barriers. It is imperative to create a conducive environment to encourage them for vaccination by ensuring easy registration process and even waiver of immigration checks and proof of residency. It is also important to launch awareness campaigns against disinformation and misperceptions and lack of trust about vaccines among migrants and refugee communities. Fourthly, administering vaccines among large-scale refugees and host communities in low-income countries is a huge capacity issue. Therefore, national governments, UN agencies, and humanitarian actors must join hands to take up this highly challenging task, especially to reach those who are at the greatest risk of being left behind. Finally, dear colleagues, at the current pace, it is estimated that we would need until the end of 2023 to vaccinate every global citizen. An effective mechanism for equitable access to vaccines needs to go beyond procuring vaccines by mobilizing the global manufacturing capacity, including in developing countries by using TRIPS waiver and flexibility. We must recognize the important link between expanding access to COVID-19 vaccines and production capacities. Ensuring vaccines as a global public good would require scaling up production massively. I shall rest it here, dear colleagues. I look forward to a fruitful discussion ahead. Bangladesh will support every effort to ensure immunization for people on the move. As a major migrant source country, as well as host to a large refugee population, that is a real-time commitment for us and a priority. I thank you all.
Her Excellency, Ms. Rabab Fatima, thank you so much for your remarks and illuminating the role of multi-stakeholder engagement, the glaring inequalities. And now I would hand over to Her Excellency, Ms. Mary Elizabeth Flores, Permanent Representative of Honduras to the UN.
Thank you for this opportunity to address you today. Excellencies, delegates, agencies, friends. The COVID-19 pandemic has exacerbated gaps, not only within, but also between countries, and challenged health systems worldwide. Vaccines can bring a sense of security and hope that the beginning of the end of the pandemic is near. Governments across the globe are striving to guarantee equity and access to COVID-19 vaccines to their populations, which are considered global common goods. According to Our World in Data, more than 90 million COVID-19 vaccines have been administered globally. Notwithstanding, there must be due diligence to guarantee that all COVID vaccines are tested thoroughly to ensure they are safe, reliable, and effective. And the manufacturing sources have a proven track record. Through mechanisms such as COVAX, millions of vaccines are being dispatched by vaccine manufacturers, where shipments will become more regular as more doses are available in the next months. We are also encouraged by events such as the One World Protected, and it's launching a campaign for $2 billion in the global fight against COVID-19 and accelerating access for lower income countries. Timely vaccine rollouts are instrumental in stopping the acute phase of the pandemic, supporting faster, fairer, and equitable social and economic recovery. The spirit of global solidarity and shared responsibility is paramount in the deployment of COVID vaccines, ensuring collaborators and equal distribution among countries, fostering international cooperation among states to tackle the pandemic, increasing efforts to provide access to low and middle income countries. To mitigate the transference and transmutation of the virus, inclusive public health measures and immunization services are key to ensure protection and accessibility to masks, sanitation, and testing. If essential health services and immunization programs are disrupted, the resurgence of such diseases occur in the under-immunized population groups, such as refugees and migrants. It is crucial that migrants are integrated into local, national, and transnational COVID vaccine strategies to reduce morbidity and mortality and limit transmission. Many migrants remain excluded from the deployment and vaccination plans. It is imperative to catalyze political will and moral fortitude to include people on the move in national immunization plans and programs, hard to reach settings and population groups, guaranteeing migrants, regardless of their status, equitable and affordable access to COVID-19 vaccines. The International Organization for Migration estimates there are more than 281 million international migrants worldwide. The 2030 Agenda for Sustainable Development recognizes the contribution of migrants to sustainable development. In the Global Compact for Safe, Orderly, and Regular Migration, states have committed to include the health needs of migrants into healthcare policies and plans and provide affordable and non-discriminatory access to basic services. The United Nations Network on Migration calls on states to guarantee rapid, fair, and equitable access to vaccines for all, and the inclusion of migrants, regardless of their status, in national COVID-19 vaccination programs and other public health interventions. Affordable, non-discriminatory access to vaccines is a human right. Governments must consider the safety of all the population in order to prioritize public health considerations without discrimination and ensure vaccination of all high-risk individuals, including migrants and vulnerable groups. The UN Refugee Agency estimates that 80 million migrants are forcibly displaced and calls for a concentrated international action in solidarity to ensure equitable access to COVID-19 vaccinations, including refugees and other displaced and stateless people. Fragile health systems, lack of coordination among local authorities, and ill-equipped international stakeholders may have disproportionate negative effects on refugees and migrants. Many of these groups ought to be the first source of contact provided health services at the border areas. Migrants face socioeconomic, social-cultural, and education barriers. When accessing immunization services in host countries, they often experience multiple barriers in accessing public and health services. They suffer discrimination, limitations in achieving regular legal status, restrictive policies, experience challenges to physical distance, and need to be in close proximity with other migrants to maintain a level of safety. Often they are employed in informal roles, live in poor, overcrowded living conditions with less access to adequate water and sanitation. They also have linguistic and cultural barriers and mistrust of authorities. Some migrants even fall victims of trafficking and are harmed or murdered. In order to avoid stigmas, information on health rights should be disseminated through local NGOs, allowing migrants anywhere to protect themselves and their communities. Refugees and migrants are not to be inhibited from accessing health services and should receive culturally and logistically appropriate immunization and practices through health checkpoints and health kiosks along established routes. Policymakers must guarantee a culturally competent healthcare service where medical staff is trained to prevent discriminatory behavior and create an inclusive approach where those in transit to their destination have access to vaccines. In this global effort, no one is to be left behind. All countries, leaders, stakeholders aspiring to create equal and inclusive societies and protect their population adequately, including migrants, refugees, and displaced people, must work together to build resilience in the face of COVID-19 and prepare for future pandemics. Thank you very much.
Her Excellency Mary Elizabeth Flores, the permanent representative of Honduras to the United Nations. Thank you so much for illuminating the challenges of migrants. Thank you so much for even highlighting the importance of global solidarity, collaboration, cooperation. And next we will be setting the scene, and starting off, we will be having Laura Thompson. Ms. Thompson has been the Deputy Director General of the International Organization for Migration since 2009. She has provided leadership for multilateral initiatives and negotiations across the fields of migration, refugees, internally displaced persons, humanitarian assistance, and human rights, gender matters, and the environment. Prior to joining the IOM, she was the ambassador and permanent representative of Costa Rica to the United Nations Office and other international organizations in Geneva, and held other diplomatic positions in Geneva and Paris. Just a quick note to note that the Deputy Director General will have to excuse herself from the event after her intervention as she has another commitment. However, IOM's Migrations Health Division Director will be present to address any questions from participants. Thank you so much, Ms. Thompson.
Thank you very much, moderator, and you're very generous with your presentation of myself. Dear Ambassador Fatima and Ambassador Flores, a pleasure to see both of you and have you here. Colleagues of IFRC and ICRC, and also the SRG COTE for COVID-19. I have some old colleagues in this participating in this, so a warm greeting for them too, and current colleagues as well. So a large amount of IOMers and former IOMers in this call. But in addition to that, very happy to have a large amount of public present in this discussion that I think is going to be very important. Since its inception, IOM has worked to improve immunization coverage for migrants across the world. As recent as last month, we launched a strategic response and recovery plan for 2020, which calls for the scale up of public health measures, including access to vaccines. As countries continue to face the impact of this pandemic, it remains vital that migrants in vulnerable situations have access to essential immunization in humanitarian settings as much as in urban slums or border communities. It is critical to ensure equitable access to COVID-19 vaccines by adequate inclusion of migrants in national vaccination.
We seem to be having technical difficulties. I am not too sure what just happened there. Hopefully the technical team can assist with me. If possible, and if you'll allow me, then we will kindly ask Ms. Laura Thompson when she's back on to continue her remarks. Maybe if we could ask Mr. Walter Cote, as the special representative to the Secretary General, to give a few remarks on setting the scene on COVID-19. Mr. Cote is the special representative to the Secretary General on COVID-19 and the permanent observer and head of delegation of IFRC to the UN. Walter joined IFRC in January 2013, first as the Undersecretary in Geneva, then as Regional Director of the Americas Office. Previously, Walter was the National Executive Director of the Colombian Red Cross Society, Head of Operations and Disaster Management, and Head of Volunteers for Relief and Search and Rescue. Walter has more than 40 years of experience in humanitarian and development experience. Mr. Cote, please take over.
Thank you very much. Good morning to you, Dumiso, and to Ambassador Fatima, Ambassador Flores, Deputy Director General Thompson. I am very sorry for the inconvenience of the connection, but I will try to deliver our message as a IFRC, but in a moment that Ambassador, the Director Thompson appeared, the Deputy Director Thompson appeared, we will give the floor to her too. I hope so. Excellencies, ladies and gentlemen, and all participants, I welcome all the public that is here and the volunteers that are accompanying us and all the humanitarians that are with us today. The International Federation of Red Cross and Red Crescent Societies and the national societies of the Red Cross and Red Crescent are playing a very important role globally and also auxiliary role to the governments in each one of the countries, alongside with communities and with 14 millions of volunteers that are working with us in the Red Cross and Red Crescent network. I believe that we are, of course, working very well on the areas that we need to impulse and to support the needs of migrants, IDPs, and other people on the move. Since the start of the COVID-19 pandemic, amidst a humanitarian multi-marathon, we need to continue to add in support of the most vulnerable people on the move across the globe. Since the pandemic started, we have seen severe and disproportionate impacts and risks that many migrants, refugees, and others on the move have faced. Also, from the start of the pandemic, National Red Cross and Red Crescent societies have engaged in a holistic response to address the health needs of migrants, to socioeconomic impacts, and protection concerns we have seen. COVID-19 doesn't care about persons' migration status, and neither should we. We need to ensure that all people on the move are included in a local and national vaccination plans, not only as a moral imperative, but also as the only way to end the pandemic, considering that no one is safe until everyone is safe. To this end, we want to highlight 5 recommendations for inclusive COVID-19 vaccination policies and rollout strategies, as derived from the recent Red Cross and Red Crescent movement report, Locked Down and Left Out. Excellencies, ladies and gentlemen, colleagues, volunteers, we challenge all people on the move, irrespective of the legal status. Number one, that they are included in a local and national COVID responses and are guaranteed access to basic services, including healthcare and vaccination services. Second, have effective access to timely, accurate, and reliable information on COVID-19 in a language they understand and through accessible dissemination services and campaigns and channels. Then, number 3, we are also including the idea that they need to be included in COVID-19 testing, treatment, and vaccination policies and rollout strategies, such as the people on the move have equal access to vaccines. 4, continue together as key stakeholders to adapt existing laws and policies to mitigate barriers to access. This includes addressing information gaps, xenophobia, prohibited costs, fear of detention upon seeking care, and digital literacy divide. Number 5 is achieve a resilient pandemic recovery through partnerships and engagement with local actors and communities, including people on the move, as co-developers and providers of a people-centered vaccine rollout. Everyone needs to contribute with that. As the world focuses on COVID-19 vaccines, we must continue to safeguard access to routine immunizations. In parallel, the pandemic has upended life-saving routine immunization programs with the potential to create immunity gaps and reverse decades of progress. Our Red Cross and Red Crescent network is working to complement efforts by governments and COVAX that focus on procuring and distributing vaccines between countries. The IFRC National Societies Networks aims to reach 500 million people through immunization activities, enabling us to advocate for equitable access to COVID-19 vaccines, build trust, support a health pillar through delivery of vaccines, reach the most vulnerable, and maintain and strengthen other immunization and vaccination campaigns, institutions, and systems. 152 national societies are already engaging in at least one COVID-19 vaccine-related activity. As such, national societies are coordinating with their respective ministers of health to support the vaccine rollout through transportation of patients, disinfection points, and risk communication and community engagement activities to combat vaccine hesitancy depending on their localized challenges and opportunities. We are very grateful to the partners gathered here today, with the voices of the ambassadors and the Deputy Director Thompson, with all the voices that we are going to hear. And you can rely on our collaboration to scale up and speed up our responses, to optimize and promote a more inclusive solution-driven COVID-19 vaccine rollout to ensure we met the needs of people on the move today and tomorrow in a sustainable manner. Thank you very much. Over to you, dear Misu.
Thank you so much, Walter Cote, the Special Representative to the Secretary General on COVID-19 and the Special Observer and Head of Delegation of the IFRC to the UN. Thank you so much for highlighting those 5 recommendations of inclusion, and that is actually in the same lens as the DDG, Laura Thompson, unfortunately before the technical mishap, as she was noting equitable access and inclusion in setting the scene. Ms. Thompson, please continue.
Thank you very much, moderator. And I'm sorry to have lost part of the presentation of the SRSG Cote, but I'm back and I hope that the technology helped us this time. Anyway, I was talking about the barriers and as mentioned by several of the precedent speakers, we have identified some barriers like specific identity cards, community vaccine hesitancy, absence of firewalls between health and immigration authorities, which is quite important for migrants, particularly in irregular status, lack of information sharing with migrant communities, and linguistic and cultural barriers, just to name a few. In our efforts to move towards an equitable allocation of COVID-19 vaccines, IOM has worked in coordination with other partners, such as the national and local health authorities, but also WHO, UNICEF, Gavi, and the COVAX partners, to monitor inclusion of migrants in national deployment and vaccination plans. These plans have a very difficult acronym that is NDVPs. But every time that I'm going to talk about the plans, I'm going to talk about this one. And I will not repeat this acronym because it will be impossible to pronounce, okay? And moreover, monitor the inclusion of migrants in the actual rollout of country campaigns. In November 2020, we signed an MOU with Gavi to reach mixed communities in humanitarian and emergency settings with vaccinations, to support routine immunizations, and to facilitate collaboration on ensuring the inclusion of migrants, IDPs, and refugees in government's COVID-19 responses, in particular through the COVAX facility. The principles of universal health coverage and the aim of leaving no
Our sincerest apologies. It seems like we are still having a few technical problems. I think in the same lens as COVID-19 hasn't had any restrictions to nationality, it seems technology can also be a tad bit of a challenge. Hopefully, I will be able to get a little bit of feedback, but just a reminder that we do have 3 key hashtags for this event. Hashtag vaccines work, hashtag World Immunization Week, hashtag vaccine equity. And maybe, if I may, if you could indulge me, the planning team, if we could move on to the moderated dialogue, and we'll try and find a way, hopefully, once connectivity comes back. I will be introducing the panelists, and the first is Ms. Fatima Himya, the Secretary General of the Maldives Red Crescent. Ms. Himya has experience experiences in the humanitarian sector for a decade, working with the Red Cross, Red Crescent movement. She was closely involved in the formation process of the Maldivian Red Crescent, contributing to the development of branches across the country and in program implementation. Himya has extensively worked in the areas of preventing communicable and non-communicable diseases, epidemic control at community level, and promoting mental health. Dr. Fuzia Shafiq leads UNICEF's work on health in emergencies and humanitarian settings. In this role, she supports UNICEF's work on advocating for children's health needs in emergency, fragile, conflict, and vulnerable health settings. Between 2015 and 2019, Dr. Shafiq led UNICEF's health and nutrition program in Yemen, dealing with the worst humanitarian crisis of recent times. Prior to that, she worked for 3 years in Afghanistan on the polio eradication initiative. Dr. Fuzia began her career in public health with the Ministry of Health in Pakistan, working with the Lady Health Workers Program, Pakistan's community-based delivery program. Dr. Esperanza, Martinez is the head of COVID-19 crisis management at the International Committee of the Red Cross. Previously, she worked as the head of health at ICRC. She was responsible for providing strategic direction to ICRC's health-related humanitarian action and for overseeing and coordinating the organization's health operations in more than 60 countries. Dr. Martinez leads her team in delivering critical health services to people, families, and communities affected by armed conflict and violence. Ms. Sanne Vendes is lead design and operationalization at the Office of the COVAX facility at Gavi. Prior to her role, she was chief of staff of UNITAID for 6 years. In this role, she led the organization's participation in interagency initiatives as the interagency coordinating group on and the Global Action Plan for Healthy Lives, SDG 3 Action Plan. Prior to this, she spent 6 years in the private sector working for the Vestergaard in various roles. She has spent 20 years working in public health. Director Ruben Mendicuela is the director of UNHCR New York office. Ruben took up her appointment in February 2020. She was the UNHCR representative in Pakistan from September 2017 until February 2020. Prior to this appointment, she was the UNHCR representative in Thailand and has had a career which spans over 27 years, and it includes a range of functions at UNHCR headquarters, as well as country operations in Thailand, Turkmenistan, and the United States. Over to you, panelists. Sorry, my apologies. I'm so used to having so many different panel discussions, but I think the first question would be to Ms. Fatima Himya. Starting off with the national context of the Maldives, would you be able to describe the challenges and opportunities for including people on the move in immunization rollouts? Ms. Himya?
Thank you, Mr. Moderator, and thank you so much for inviting me to this panel. Very proud to be part of all women panel as well. Before I begin, let me give a brief about the country context here in the Maldives. Maldives is a country with a population of just close to 500,000, with very geographically dispersed islands scattered across the country. And as of 27th April, a total of 28,202 COVID-19 cases have been reported in the country, with a total of 3,700 active cases currently and 71 deaths recorded due to the disease. On the onset of the outbreak, it was very clear that the pandemic, which was spreading through the community, has affected a disproportionately greater number of migrant workers living in the capital than the locals living in the city. And migrant workers remained at greater risk of contracting the COVID-19, especially due to their harsh and very congested living conditions in the capital here. According to a United Nations report published in 2020, there were only 2,400 migrant workers in the year 1985, but the numbers increased to 180,000 in 2020, of which 63,000 are estimated as undocumented migrants. And these numbers vary between 145,000 to 230,000, as we do not have an exact figure of these undocumented migrants. Migrant workers are in large part a majority of the workforce in the country and constitute 1/3 of the population. They are mostly young men between 20 and 34 years, majority working as unskilled laborers in the country. Migrants in the community face discrimination and exclusion, sexual exploitation, language and cultural barriers, informal and formal barriers to accessing essential services, the fear and reality of deportation, deceptive recruitment practices, wage theft, passport confiscation, unsafe living and working conditions, excessive work demands, and are often subject to the corrupt practice of quota trading. This harsh reality has led to a significant increase in the number of undocumented migrants in the Maldives over the past years. Some of the challenges faced by the migrants in the country, many of the undocumented migrants depend on daily earnings to arrange their meals and shelter. With the COVID-19 outbreak and lockdown that was put in place in the capital, the migrant population was very severely affected. And many migrants faced economic hardships due to the loss of employment and had challenges in accessing healthcare and food. Maldivian Red Crescent provided over 400,000 meals to 10,000 migrants throughout last year in an attempt to reach to the most vulnerable. Throughout the lockdown phase, MRC also worked with authorities to ensure access to healthcare to undocumented migrants by issuing beneficiary card as a form of identification, which enabled access to healthcare services, which was very essential during the COVID-19 outbreak to ensure that they were given the medical treatment as necessary. MRC also extended its assistance in the work towards countrywide COVID-19 immunization, and particularly towards the registration of the migrant worker population living in the Maldives for the COVID-19 vaccine. To address and fill this gap in providing access to vaccine for undocumented migrant community, on 20th February this year, we initiated a process to register undocumented migrants for the COVID-19 vaccine through an online registration system, which we refer to as the MRC beneficiary system. This is a system that is being managed and looked after solely by the Maldivian Red Crescent, as in the beneficiary card issued is a means of verification for the migrants when they go to the vaccine centers to get the vaccination. So the database is looked after and is being managed and handled by the Maldivian Red Crescent. With effective dialogue with key stakeholders, MRC was also able to fast track the vaccination of the undocumented migrant workers. And on 24th February, the vaccination for undocumented migrants began, which was an incredible milestone in the COVID-19 immunization work to ensure vaccine equity and to leave no one behind. MRC is very proud to support this process and work with the government in its commitment to vaccinate everyone in the Maldives. Some of the challenges that we face, many undocumented migrants in search for paid work or to escape from unpaid employment usually move from one island community to another. While some do settle in one location, there are those who are on constant move. So this makes it very hard to reach out to migrants, and also especially in something like immunization, when 2 doses are required, it is very challenging for us to ensure that they are reached and the information required is passed on to them. The language barrier and poor level of literacy among members of the migrant community leads to communication gaps and makes ensuring access to accurate information a continuous challenge. About more than 90% of the migrant population are said to be illiterate, and as an organization working closely with migrants, we have to continuously work on ways to overcome this barrier to ensure access to right information. And years of struggle and injustice towards the migrants in the country has resulted in lack of trust in the established systems of the country, which makes it very challenging to persuade the migrant workers to come forward and seek help. Given these challenges, we also have seen some opportunities, especially during the COVID-19 outbreak and the vaccination immunization process, which has enabled MRC to work more in this area. One of the biggest advantages we have as a national society is our presence at local level. Through community engagement, we are able to reach the most vulnerable migrants in the remote island communities and roll out our programs across the country. Since its formation, MRC has also engaged with migrants, especially in ensuring access to information by translating awareness material into different languages. The continuous advocacy on the protection of migrant workers has built the trust of migrants to come forward and seek support from us. The current ongoing operation of registering undocumented migrants is evidence of the trust of migrants towards the national society, as we have now more than 4,000 undocumented migrants registered with us for the immunization program. As a key auxiliary to the state, guided by our fundamental principles, MRC continues to promote the protection principles and continues to advocate and wherever possible, integrate the concept of do no harm, providing undocumented migrants the protection and support the way they very much need. Over the years, MRC's continued work with migrants have earned the organization respect and trust among migrants as well as stakeholders. Strong partnerships with both state and non-state actors is key in working to address issues related to migrants. A problem of such magnitude cannot be addressed by just one organization or by the state itself. As such, the success of the work done by MRC strongly relies on the opportunities and space created by the government authorities for MRC to function in such circumstances by trusting us and allowing us to work independently and close partnerships MRC has established with UN organizations, the IOM and other NGOs in the country. It is vital that we all work together to ensure that everyone, including documented and undocumented migrants, are included in local and national vaccination plans, leaving no one behind. Thank you.
Thank you so much, Fatima Himya, for those insights at a country level context, and more importantly, illuminating some of the challenges and plight of migrant workers. Then my next question would be to Ms. Ruven Mendikwela. Given the goal of ensuring inclusion of refugees in national vaccination programs, what does UNHCR see in terms of member state willingness to include refugees in national and local level vaccination plans? Please do give us some examples on what UNHCR is doing to ensure refugees are included in national vaccination programs. Ms. Mendikwela.
Thank you, Dumiso, and congratulations on a really creditable attempt to pronounce my name. It's not everybody who can get it right. You did a wonderful job. Thank you very much. In response to your question, I'll make 5 points. I think that's probably in the interest of time. The first is to provide you with a statistical overview of where we are in terms of the world's forcibly displaced, who are the populations of principal concern to UNHCR. I can say at this point in time that there are over 65,000 documented cases of COVID amongst our populations of concern. Again, this is severe underreporting because we know that the majority of the world's displaced are in countries and locations where systematic documentation and treatment of COVID cases is not available. And therefore, this is very much a statistic that has to be taken with a grain of salt, but it still shows the enormity of the problem that we are confronting. The second, on a far more positive note, is that of the 157 countries that have already articulated their policies in relation to immunization in their countries, 106 have explicitly included the forcibly displaced in their national immunization plans. And of these, 29 have actually started the rollout of the immunization campaign, including towards refugees. And these are representative of every region in the world. So it's Uganda, Kenya, Rwanda, Brazil, Iran, Pakistan, Bangladesh, Spain, Turkey, Jordan, Lebanon, Egypt. So it's a wide swathe of countries, and they really have shown incredible compassion and generosity in including refugees in their programs. But of these, so 106 have basically included refugees in their immunization campaigns, but 12 countries, more disturbingly, have explicitly excluded refugees from their immunization campaigns. And 39 others are still considering their policy towards the displaced in relation to their immunization campaign. So this is kind of a statistical overview that I really would like you to have. The second is, what are the principal challenges? So one I've already articulated, that is the fact that a handful of countries, admittedly a small number, but still extremely concerning, have basically said they're not prepared to immunize the refugees and other displaced persons on their territory. I think Ambassador Rabab and others before her have also said, no one is safe until everyone is safe. And I think this is a mantra that we are repeating everywhere. And this is certainly one of the principal advocacy issues that we have in relation to these countries, and really a serious concern to us. The second challenge is that while these 106 countries that have included refugees in their immunization campaign have shown incredible generosity in doing that, as Ambassador Rabab has said, 80% of the world's displaced are hosted by developing economies. So while these countries have articulated their immunization campaigns and explicitly included refugees amongst the people who are eligible for the vaccine, many of them do not have the resources or the financial means to actually implement these programs, and they require support. And then the third is something that you mentioned yourself, Demiso, which is vaccine hesitancy. In the 29 countries where we have seen the rollout of the vaccine, we have noted a certain number of refugees who are reluctant to avail themselves of this option of getting themselves immunized for a whole host of reasons. Some of it is cultural. They don't understand vaccines. They don't understand the importance of it. So some of them are extremely skeptical of the efficacy of the vaccine. And in others, there are also cultural norms and taboos that prevent them from being inoculated. And again, I think this is a very similar debate to what's happening with other populations across the world as well, including in the United States, in relation to whether or not to be vaccinated. So those are the three main challenges that we're facing right now. So what is UNHCR doing in relation to this? So the first is the countries that have explicitly said they're not prepared to inoculate refugees on their territory. We are advocating with them constantly through our national representations, but more importantly, we're also doing it through our donors and the IFIs, the international financial institutions like the World Bank and regional development banks, saying, look, the World Bank, you are providing funding instruments at the disposal of these countries to help them with their immunization programs, but also to fund their socioeconomic recovery. So please, when you're providing these funding instruments, make it a condition that these governments do include refugees in their immunization programs and in their socioeconomic recovery plans. So this is a part of the massive advocacy effort that UNHCR is undertaking right now. The second is in relation to the governments that have said they are prepared to inoculate refugees on their territories, but who don't financially have the means to do that. And again, this is something that we're working on extremely closely, not just ourselves alone. This is very much a collective effort. We are doing this with a lot of our humanitarian partners, including UNICEF, WHO, and most importantly, the national governments concerned. So we are undertaking a wide gamut of activities in this regard. One is, of course, providing key population data regarding the most vulnerable, regarding the displaced in these territories to make sure that they are taken into account in the immunization programs. The other activities that we're doing is establishing vaccination sites, providing cold chain storage facilities for storing the vaccines, providing assistance with transportation of the vaccines, training medical personnel to administer the vaccines, and various similar activities of that nature. So this is what we're doing to try and respond to the governments that have very, very courageously said that they are going to be inoculating refugees on their territory. And then the third is the vaccine hesitancy on the part of the refugees themselves. This is something that's fairly sensitive and critical. We are mobilizing the communities, the refugee communities themselves, to convince their own peers, look, you do need to get yourself vaccinated, because if you don't do that, you are endangering the whole community. We are also coming up with common messaging that we are now providing to all our local partners as well, to make sure that these messages are disseminated about the safety of the vaccine and the importance of being inoculated. So those are the challenges and the solutions that we're looking at. And just two last points before I conclude. One is on the COVAX humanitarian buffer. Now, I know there are two panelists who are going to be coming after me who are experts on this issue of COVAX and who are going to be speaking to this. But I just did want to mention the fact that the COVAX facility does have this humanitarian buffer that will become operational next month and would make available up to 5% of real-time doses for people at high risk and vulnerable populations in humanitarian settings. However, I do have to underline, this is really an option of last resort. This is not something that we would be favoring as a first resort. Our focus is very much on encouraging and supporting national governments to provide the means necessary to inoculate the refugees. But this is an option that is there, and something that I just wanted to mention. And then finally, I just want to point to something that may sound a bit counterintuitive in an event where we're talking about the importance of vaccines. But just to say, humanitarian funding is a critical issue. But as you know, probably, and certainly a lot of the participants here as well, humanitarian crises have multiplied in the context of the pandemic. In the last 12 to 14 to 16 months, we have seen a multiplicity of humanitarian crises that are stretching our resources extremely thin and stretching the resources of the host governments as well. So what is critical is that we do not divert core humanitarian funding to fund immunization campaigns. Because I have to be quite honest with you, for many refugees, the pandemic is not the most serious problem they're encountering. For many of them, they have far more serious problems on trying to access physical safety, trying to find a roof over their heads, trying to figure out when their next meal is coming from, trying to figure out whether they're going to get medical attention that they're desperately in need of. Those are far more vital to them than being inoculated. And we have to bear this in mind and to make sure that we do not divert core humanitarian funding to immunization programs, and that any funding that comes to immunization programs has to be additional and over and above the core humanitarian funding. So I'll conclude on that note. Thanks, Dimiso.
Thank you so much, Ms. Ruben Menikduela, Director, UNHCR in New York. So many interesting insights, especially in the role in which UNHCR plays in advocating at a country level, as well as sort of reminding us that COVID-19 isn't just the only challenge. Next, I would then maybe just remind our audience to continue posting questions in the comment box, and I will turn to the head of COVID-19 crisis management at ICRC, Ms. Esperanza Martinez. What are some of the specific challenges to delivering vaccinations to vulnerable groups, along with the last mile in fragile and conflict settings? Ms. Martinez?
Thank you, Dumiso. And I would like to really link my points to what Ruben just said, and it's the fact that for populations that are affected by having to be displaced or displaced, forcibly displaced, or moving away from armed conflict, COVID-19 is one crisis on top of many, many different crises they are facing. So one of the elements that is quite important to highlight is that a response to COVID-19 has to be embedded within a multidisciplinary approach. We cannot just tackle it only from a COVID perspective. And I would like just to bring attention to three key challenges that are specific to areas affected by armed conflict. And one of them is the element of infrastructure. So very often we face humanitarian crisis in areas where half of the infrastructure, a big part of health centers, medical facilities, and hospitals have been destroyed. And this is going to really pose a major challenge when we talk about reaching the last mile, reaching those communities, particularly communities that are hosted by already very disadvantaged and at-risk populations, because the access to services is already very low in terms of level of access, or really of very weakened quality. Now, when we look at the issue of infrastructure, we are not talking only about health infrastructure, but also to be able to transport vaccines and to vaccinate populations. You also need road infrastructure. You also need warehousing. You need ports. You need airports. And very often you find those affected by armed conflict. And here I would like to make an emphasis on building on the fact that humanitarian crises have not stopped, but also the obligations under the rules of war, international humanitarian law, have not stopped because of the pandemic. So it's also a reminder that parties to a conflict need to be very mindful and aware that there is a need to protect infrastructure. There is an obligation not to attack hospitals and health facilities, and also to preserve essential services like water and sanitation, which are so critical in this pandemic. So that's one of the main big challenges that we face and we will continue to address. The second one is the element that wars and conflict and insecurity in general affect not only communities and including refugees, internally displaced, and migrants, but also affect healthcare workers. And sadly, we have seen in the past vaccination teams are under attack, and because of this perception, because of lack of trust. And this is an element that we need to consider when we move forward. And I saw a question in the chat in relation to what role, for example, nurses and midwives will play. And I think this is one of the largest endeavors in terms of vaccination and health undertaking that we as a global community are basically going to do. The rolling of vaccines, but really the scaling up of this effort will require the engagement of all healthcare workers in a given context. And this is much more important in areas affected by armed conflict. We often see the diminished number of healthcare workers, including doctors, nurses, vaccination teams, midwives, and community health workers and volunteers. So everyone will play a role, either being providing the vaccines themselves or really mobilizing communities and generating trust. There was already mentioning of vaccine hesitancy, and in armed conflict, vaccine hesitancy can not only generate the rejection of the vaccine, but also can generate attacks against vaccination teams. So we need to be very mindful of that. And the role that community volunteers, civil society organizations, community leaders play on this is quite critical. And my last point is that we very often find that for people that are forcibly displaced, particularly internally displaced people, undocumented migrants, refugees, they often end up detained, deprived of freedom. And there's added an additional element, because when we look at the health of detainees, in many different countries, it doesn't fall under the remit of the Ministry of Health. It might fall under the remit of the Ministry of Interior, of the Ministry of Defense. And therefore, when we talk about national vaccination plans, we need to really discuss with authorities that those populations that are in detention, including refugees and undocumented migrants, they also need to have access to healthcare, and including vaccination services. So this is just to say that when we look at the next stages of what we need to do globally, we need to consider that populations, including refugees, migrants, and displaced communities living in armed conflict, have these layers of crisis and layers of need that need to be addressed. So we need to look at the issue of COVID-19 vaccination and the maintenance of infection prevention and control, really in this comprehensive framework. We all play a role, and humanitarian actors play a role. And a final point in relation to international humanitarian law is that in contexts where the state is not able to ensure the access to essential services for refugees or for communities affected by armed conflict, then there is an obligation under international humanitarian law to allow humanitarian actors to perform their role. And that's also an important thing to say, because then there is the element of leaving excluded populations. How do we find a way to make sure that they are not excluded in COVID-19 vaccination? Thank you.
Ms. Esperanza Martinez, Head of COVID-19 Crisis Management at ICRC. Thank you so much for some of those insights, addressing one of the questions, and even speaking to I think the pertinent issues that need to be addressed by a multi-stakeholder approach. Much appreciated. I will then move on to the lead design and oh my goodness, my English is going out the window. At the office of the COVAX facility at Gavi, Sane Vendes. My question to you is, are people on the move included in national vaccine rollout plans? If so, how are they included? What strategies are being implemented by the COVAX facility to meet the needs of people on the move who have been left behind in national action plans? I think we already had a little bit of an answer around that by Ms. Mendicuela. So maybe if you could please expand on that, Ms. Vendes.
Thank you very much. And thanks to all the speakers for this. I will, as I think the only speaker, indulge myself in using a few slides to just explain this. So one of my colleagues will pull them up in just a second, which hopefully will be okay, but it will help you to maybe speak to one of Ruben was speaking a bit about the humanitarian buffer that the Gavi, the COVAX facility is putting in place. And so we wanted to share with you a little bit of information about that, and then I'll come to your question more specifically towards, okay, sorry, I just see that screen share is disabled. So let me see if I am, nope, sorry, we can't screen share. All right, so apologies, technical challenges here. Let me try to speak through it. I understand that there's not a possibility to share slides right now. Okay, good, that's not a problem. I'll do it without that. Since the facility's inception, it was discussed very early on how to ensure that as part of the fair and equitable access that the COVAX facility is aiming for, a flexible buffer of doses could be made available as a safety net. The Gavi board, we've been working with partners, and many of the partners who are on the line today have been part of developing the COVAX buffer. And the Gavi board recently approved the establishment of the COVAX buffer. And today we're working with all of these partners as well to ensure that we can operationalize the mechanism and ensure access to the vaccines for populations globally, including those in humanitarian settings. And thank you very much for sharing those slides. Fantastic. So it's many of the speakers spoke to this very important notion of the buffer being a last resort. And we'll come back to in a second Demiso, your question around making sure that the plans include these populations, because that's first resort. And we really need to ensure that countries are covering these populations of concern in their national deployment and vaccination plans. So the intent of the humanitarian buffer is that it would be a last resort. Countries should include all populations at risk on their territories in their NDVPs, in their national deployment of vaccine plans. However, in certain cases, there will be unavoidable gaps in the vaccination plans, and the buffer is here to assist these situations. So countries and humanitarian organizations will need to demonstrate why the populations of concerns are not included in the NDVPs, in the plans. And for countries, they will additionally need to demonstrate that the populations of concern are new or are unaccounted for in their population consensus numbers. Humanitarian agencies will need to show that they have the experience in delivering vaccination campaigns in humanitarian settings and that they have the ability to reach the populations of concern. The IASC is the Interagency Standing Committee, is the decision-making group that will allocate the doses as they become available and manage the application process and selection process. We move to the next slide. So the buffer envisages to be a demand-based and revolving mechanism that will take 5% of all COVAX doses procured through the facility. The buffer has two elements of it. It has the humanitarian buffer, which we'll talk about here today, but it also has the contingency element of the buffer, and that is intended to provide the flexibility to enable an emergency release of doses to meet public health needs where normal vaccination allocation timelines would not be sufficient. This is something that we're working on and that we will be operationalizing once we have a baseline coverage in all countries. And we heard numbers in the beginning of this of how some countries are only just getting started on their vaccination plans, and we want to make sure that all countries have an access to a baseline coverage of doses. But if we turn our attention to the humanitarian buffer, it is intended that the doses would be deployed through countries and through humanitarian agencies, as just explained before. The territories of deployment would be AMC, and AMC in this context means countries that can benefit from funding through the advanced market commitment that COVAX has put in place, which means 92 countries that can have access to fully funded doses through the COVAX facility. Self-financing participants are the participants that are accessing or paying for their doses themselves as elements for this as well. If we move to the last slide, and this is the slide that really speaks to the question at hand as well. And the Interagency Standing Committee has estimated that around 167 million people are at risk of exclusion from COVID-19 vaccines or vaccination. And I won't go into the details of these, but you can see the numbers here that are looking at what types of population groups these are. Of course, these numbers are highly variable, and you are the subject matters, many of you on this call, on these, and they're also subject to unexpected shocks as well, which, for example, are due to conflicts and other agencies or other issues that we've heard on this call. Now, we've done an analysis of the NDVPs, the National Deployment of Vaccine Plans that had come through, and the latest analysis as of April 1st had taken a look at which of these countries are including these populations. So 12 countries included, out of the 104 that have been analyzed, 12 countries included only regular migrants, 17 countries included all migrants, 40 countries included refugees and asylum seekers, and 38 countries included IDPs, internally displaced persons. So this does tell us that there most likely is still a gap in terms of the coverage of these populations. And it's very important that we work together as partners to make sure that these NDVPs really address these population groups, and that we're including them in the national plans, so that the number of doses that we can have through the humanitarian buffer are really saved for those situations where it is not possible for us to cover them through the national vaccination plans. What we're working towards today is to roll out the vaccinations through the humanitarian buffer according to the same guidance as we're rolling them out in countries, which means focusing on the SAGE high-risk groups in terms of rolling these out. So the initial 3% following up to the 20% of the populations, and rolling that out at the equitable pace as well as within the countries. So this was to give a little bit of a highlight of what the humanitarian buffer looks like. And efforts are being done. And I'd like to thank all of the partners, and thank you for posting in the chat by one of the interagency standing committees groups as well, the frequently asked questions around the humanitarian buffer. It was mentioned that we're hoping to launch this in the coming weeks and be able to address and roll out the doses to these population groups that are highly, highly important that we cover as well. With that, thank you very much, and back to you, Damiso.
Thank you so much, Sane, especially highlighting and helping us visualize the gravity and the important work of the COVAX facility. I think, just in the interest of time, we will then move on to Dr. Shafiq. The question is given UNICEF's decades of experience as a key role in global immunization campaigns and as a formal partner of COVAX, what challenges does UNICEF anticipate in COVID-19 vaccination plan rollouts? Please do share some advice for MS and partners on how to bring COVID-19 vaccines to migrant communities. And thank you so much to some of the speakers who are already answering the questions. Dr. Shafiq, over to you.
Thank you. Thanks for that very important and very pertinent issue. Just checking that you can hear me clearly. Okay, I'm assuming that you can. So if I may, let me begin by saying that, in the bigger scheme of things, when we look at the total number of people that need to be vaccinated globally, the population that we are discussing today may make a relatively small proportion of the number of people that we are trying to vaccinate. But I think whether we are or are not able to reach them with the solutions that we have available, including the vaccination, will be a reflection on the whole global community in terms of how successful we are in keeping human rights and equity as our guiding principles in the fight against the pandemic. And we at UNICEF feel strongly that we need to keep reminding ourselves and our partners of the centrality of human rights and the equity principles when we are talking about refugees, migrants, displaced populations, and people on the move generally. And as you said, yes, indeed, UNICEF and our partners, we do have decades and decades of experience in making vaccination a reality for people across the globe, but especially the most remote and hard to reach populations in some of the most fragile and sometimes the most dangerous places on the globe. From the days of the universal child immunization to introducing new and underutilized vaccines with support from Gavi and other partners on the forum today, to polio eradication efforts, we, along with the partners, have delivered vaccination to children and their mothers, and indeed some of the most challenging operating environments and most difficult to reach populations across the globe. So luckily, as a global public health community, we do have all of that experience in overcoming challenges to access, to acceptance, to logistics at our disposal that we can use and build on. However, as a reminder to all of us, we know that COVID vaccines are quite different from childhood vaccination. We are talking about different age groups. We are talking about multiple products, sometimes within the same country, sometimes for the same population segment. We are talking about lack of experience of trying to vaccinate a large proportion of our population, especially adult population, at the same time, and the sheer scale at which this is being rolled out globally. So there are a lot of new scenarios and a lot of new challenges that we are dealing with. As of last evening, just over 1 billion people, just over 1 billion doses had been administered globally. Around 500 million people had received at least one dose, and just over a 250 million people had been fully vaccinated with the COVID vaccination. But as we move forward, every day makes it more evident that we have challenges around national vaccine nationalism. We have challenges when countries are trying to prioritize between the global versus national priorities, especially those countries that are vaccine producing. And we are seeing shocking disparities between high and low income countries becoming more and more evident every day. Now, while we do not have the breakdown, we do know, unfortunately, that of the 1 billion doses that have been administered, very few have gone to low-income settings, and fewer still to the populations of that we are discussing today. So just alarming situation really that we are seeing. Now, as part of the COVAX facility, we are learning from our past experiences, but we are also seeing some challenges that are much more exacerbated now than they were in the past. Some of those I've mentioned already, but some of them also have to do with the very short shelf life of the vaccine that requires that we have all elements in place at the same time. We need the vaccines, we need the devices, we need other financial resources, well-trained workers, transportation, and we also need a community that is ready to accept the vaccine. And all of these needs to come together in a relatively short period of time, with some vaccines having shelf life as short as 3 months. And then in a world that is more connected than ever before, we are seeing that rumors spread fast. And when there are even real safety concerns, and the scientific community tells us that the benefits far outweigh the risks, even then the fear spreads fast. And so we are seeing vaccine hesitancy become a real challenge globally, irrespective of the economic situation of the country, but particularly in the refugee and migrant populations as well, from some of the early data that we are beginning to receive from countries. Now, the operational challenges in the regular environments are pretty significant. So you can just imagine how much worse they are when we are talking about fragile, vulnerable, and conflict settings, and the populations that are displaced and on the move. We have 2 surveys, one from the socioeconomic impact survey that UNICEF has been conducting, and the WHO Essential Health Services survey, that both cover over 100 countries, most of them low-income settings. And as one of the speakers said, the countries that house most of the refugees and migrant populations. And in these, we are seeing that the disruption to health services was twice as much in the fragile settings than in other settings. And we're also saying that the scale of these disruptions was 2 to 3 times higher in these settings than in others. So we're also finding ourselves trying to deliver vaccines to the population on the move using health systems that have already suffered a lot due to the pandemic in the last 18 months. Now, I guess the advice for all of us has been from the beginning to include all populations, irrespective of their legal status, to the national vaccination plans, in line with the SAGE recommendations, prioritizing the frontline workers and the elderly and those with other health issues. And the advice of the member states, which most of them have taken, is to use the same SAGE criteria to identify priority populations within the populations on the move, the migrants and the refugees. A lot of figures have been shared, so I will not repeat them, but just to say that when we talk about international migrants, for most part, they have been left out of the national vaccination plan. Situation is much better when we talk about refugee populations, which have been included in most plans. And when it comes to displaced populations, it's a mixed bag, with some countries having included them, others having not included them. I think the challenge now is twofold. We continue to advocate with countries to include the populations that have been left out to the plans. That has been successful in many instances. And so we are seeing countries revising their plans and including these populations in the plans. But the second challenge is, even for the countries that have included these populations in their plans, we need to make sure that we are doing regular monitoring to make sure that those plans are actually implemented as they have been presented. Because we do have a couple of examples where vaccination rollout has begun. The refugee and international migrants were included in the national plans, but as implementation is happening, we are not seeing vaccines go to these populations yet. And so that's something to keep an eye on. And just to remind ourselves that this is not just the right thing to do as members of global community, but it's also the right thing to do epidemiologically. And the slogan that we've seen many colleagues repeat today, that no one is safe until everyone is safe, is not just right from the human rights perspective, but it's also epidemiologically and scientifically the right message to be giving out to everyone. Now, WHO, UNICEF, IOM, UNHCR, IFRC have been working together to help member states map these populations and to monitor the vaccination of these populations. And I think we need to make sure that we continue to collaborate, share information with each other, because problems will keep coming up and we will have to address them contextually based on specific situations. And a lot of interventions have already been mentioned. And again, I won't repeat them, but just to say that we are on standby to provide support in identifying the right strategies in terms of vaccination strategies to reach these populations, depending on the context and location, but also the right communication strategies that need to address not only these populations in the languages that they understand, through mediums that they have access to give them clear messages on where and how they can access vaccination, but also communication with the health workers to make sure that they are welcoming and are open to vaccinating these populations as well. And lastly, just to repeat a concern that has already been raised, when we talk of migrants, refugees, displaced populations, populations on the move, in fact, when we talk about humanitarian populations in general, we cannot go to them with COVID vaccination alone, especially not in areas where there has been disruption of routine vaccination or there has been disruption of health services. When we reach these populations after having overcome all the challenges around access and acceptance and utilization, we have to do so with a package of services, including vaccination, other vaccination and other health services as required. A reminder that in Ebola experience in DRC, more children died of measles outbreaks than they did of Ebola. And so while COVID vaccination is really important, we must take the vaccination along with other health interventions that some of these populations require immediately. Back to you, please.
Fouzia Shafiq, thank you so much for your insight. And in the interest of time, just to mention that we will be having closing remarks by Her Excellency Mrs. Griselda Lopez, Permanent Representative of El Salvador to the United Nations. And just to finish off some of the talking points that Laura Thompson had earlier, the Deputy Director General of IOM, we have Jacqueline Weekers with a few talking points. IOM Migrations Health Division Director. Jacqueline.
Thank you very much for giving me the floor. Actually, I've been trying to give some comments in the chat meanwhile, and I will limit my comments to various migration-specific issues that were not yet mentioned. On reaching out to migrants and other hard-to-reach populations, let's not forget to engage with migrants themselves. Around the world, migrants also are at the front line of the COVID-19 response, working as co-developers and providers of essential services innovations. And social mobilization and community engagement includes migrants themselves. Fouzia, indeed, thank you so much for your comments. The feedback that we have from our country offices around the world shows that in many locations, whether that's low, middle, and high-income countries, it's the migrants in irregular situations that are risking of being left behind in the vaccine campaign mostly. And so this is a great concern for us. In terms of barriers, we heard about the admin barriers. These are omnipresent, need for ID cards, residency cards, and so on, as well as linguistic and cultural barriers and so on. We must bear in mind that this is not just about the health sector. And so the solutions for these barriers, think of ID cards, will not be just with the health sector. Obviously, we'll have to engage other sectors of society to find solutions. The two-dose issue. Beautiful example. This is about coordination among communities and among countries of origin, transit, and destination. Vaccine passports. Evidently, the requirement of proof of vaccination cannot mean that we deepen the inequities and promote differential freedom of movement or only movements from the north to the north. That would not be of any use. Lastly, as the coordinator and the secretariat, IOM highlights the possibility to engage on these issues, very closely linked to universal health coverage, within the United Nations network on migration. So working towards migrant inclusive national plans undoubtedly contributes to the objectives of Global Compact for Migration and to shaping greater coherence in both migration governance as well as health policies. I leave it at this. And thank you so much for thinking of giving us the floor. Thank you. Over.
Thank you very much. Thank you very much, Jacqueline Weekers. And in the interest of time, I will hand over for the closing remarks to Her Excellency, Ms. Griselda Lopez, Permanent Representative of El Salvador to the United Nations.
Thank you, Mr. Moderator, for giving me the floor and for conducting this important and timely discussion on access to immunization for people in the mood, considering also the challenges posed by the current COVID-19 pandemic. Our appreciation to IFRC, IOM, and ICRC for coordinating this event, and all the briefer for their insightful presentations. Health is a basic human right. However, people on the move are excluded from health systems due to legal and policy frameworks, limiting or prohibiting their access to healthcare. This situation may hinder people on the move's ability to make preventive measures against COVID-19 and to receive medical care if needed. Therefore, let me be clear, information is key. Having access to medical information in different languages and by different means is crucial for people on the move's capacity to effectively prevent the virus, but also to combat misinformation, as expressed by the UNICEF representative. Health quality access must be guaranteed to all people. Therefore, timely and equitable access to the COVID-19 vaccine must be the central issue that defines the current international agenda. And we call all states for the inclusion of people on the moves into their COVID-19 vaccination plans. And we welcome those member states that have already done so. Vaccine nationalism has no place in this world. In this regard, we recognize WHO key's role during this pandemic response and recovery process. And we also commend the work of IOM, IFRC, and ICRC, and invite more partners and other potential donors to support countries of origin, transit, and destination to contain the COVID-19 pandemic and to address the new challenges faced by people on the move during this context. We call on all countries and potential donors to support the efforts of low-income and middle-income countries to effectively respond to the COVID-19 pandemic, not only regarding the vaccine access, but on the path to social and economic recovery. Dear friends, as Ruben from UNHCR office in New York accurately expressed, our current mantra is no one is safe until everybody is safe. And in this sense, solidarity and a strengthened international cooperation are imperative to ensure an inclusive access to COVID-19 vaccine, especially to people in vulnerable situations, regardless of nationality or location, and without any kind of discrimination. And this was precisely the commitment in the political declaration on equitable global access to COVID-19 vaccine, endorsed by 175 member states. COVID-19 has only intensified the vulnerable conditions of people on the move. As Esperanza from ICRC conveyed, COVID-19 is only a crisis on top of many crises for people on the move. And in this sense, creative partnerships should be established not only to face the current challenges of the pandemic, but on the way forward. From our national experience, interinstitutional coordination, strong leadership, and international cooperation have enabled us to improve the access and quality of our health systems, even amid the pandemic, and also to be one of the countries in Central America with fewer COVID-19 active cases. Moreover, we have been able to vaccinate 500,000 Salvadorians in our territory, and with the aim of taking care of our population abroad, our consulates have established partnership with relevant stakeholders to provide Salvadorians abroad access to the COVID-19 vaccine. Their work has been crucial to engage with communities of Salvadorians abroad to better understand their needs and provide solutions in these challenging times to fight the pandemic. This engagement is crucial, as mentioned by Jacqueline Weekers just a few moments ago. Dear friends, to conclude, I would like to recall that this pandemic has not distinguished between nationality, race, sex, ethnicity, migration status, sexual orientation, and gender identity. However, it has disproportionately affected those who cannot have free and secure access to health system, which frequently also have the conditions of persistent vulnerabilities. That is why working together, we will overcome this pandemic and future pandemics, considering global solidarity and multilateralism the paramount to address these challenges. I thank you.
Her Excellency, Ms. Egrizelda Lopez, Permanent Representative of El Salvador to the United Nations, thank you very much for those beautiful closing remarks. Thank you to the logistics team. Thank you so much to the organizers. And more importantly, thank you, participants and audience members, for indulging us in this last an hour and a half and just sort of giving us a little bit extra of your time. My name is Dumiso, Advisory Group Member of the Civil Society Engagement Mechanism of UHC 2030. May you have a lovely morning or evening or afternoon. Thank you.
Thank you very much.
Thank you very much. Thank you. Bye-bye.
Bye-bye.
Thank you.
Thanks, everyone. Bye.
Thank you.